I would very much like to introduce some kind of a thinking out of the box way of thinking about breast cancer terminology, because I discovered a lot of problems with the terminology of breast cancer to the extent that we don't understand each other. And it's pretty schizoid sometimes to experience that the terminology is perfect when describing parotid cancer or prostate cancer, but totally chaotic when it comes to breast cancer. We come up with a proposal to unify the classification of breast and prostate cancers based on the anatomic site of cancer origin. Let me involve you in this. When we studied anatomy, urology, we heard this sentence that the anatomic structure of the breast and the prostate are similar. What do they mean? Did they mean pathology too? Benign, malignant? But I'm going to fill in this sentence because it's true. And I'm going to use three-dimensional histology. It's going to be very enjoyable for you. One thing is definitely sure, namely, both of these organs are fluid producing. And the fluid is produced in the cells of the gland, and the unit of the gland is acinus or acini. Now, if a fluid is produced, it better come out, so there has to be a duct as well, and an opening. Indeed, here is the picture. In the breast, three-dimensional, here are the fingers, the acini, and here is the duct, subsegmental and major duct. Likewise, here are the acini in the prostate, and here is the duct in the prostate. If I only talk about the breast for a second, and again showing these nice finger-like acini on 3D, but now on a lower and a higher magnification and conventional histology, this is the basement membrane and the myoepithelial cell layer, and these wonderful cells are producing milk, and I really admire these cells because they are making milk out of blood. Imagine that in these resting atrophic TDLUs, gradually a change takes place, and that change is called metaplasia, apocrine metaplasia. So the cells are going to change to these cylindric long cells, and they stain pink. And they don't do anything else but produce fluid. And the ever-increasing pressure. One single acinus, this used to be so small, now it's so distended. There will be a distension. And unfortunately, this ugly fluid can come out to the surface of the nipple, either spontaneously or it can be squeezed out. And I don't think that there is any woman in the world who likes to have these greenish, grayish, cloudy, ugly fluid, which actually comes from these cystic dilatations of the acini. So the fluid accumulation within the duct, which is originally pleated and measures about 0.1 millimeter, may be gradual. So we are going to get duct ectasia, and the fluid inside is going to accumulate, but gradually getting more and more concentrated because the water is going to be absorbed. So we got this very highly proteinaceous fluid, and it has some relevance for your and my practice, namely, it may calcify within the pre-existing duct, and that we call secretory disease type, plasma cell mastitis type calcifications. There is nothing that expresses all this, what happens at the level of TDLUs and the ducts, than the three-dimensional histology and its reflection on the mammogram or on a galactogram. The ducts are pleated, but they also have this twist, which makes it possible for the fluid, and there will be cysts or distension. A very similar thing can happen in the prostate. If there is a stagnation, of course, this gland is going to distend. Tell me which one is breast and which one is prostate. There is no chance you can say that. This one is the breast and this one is the prostate. The duct is distended and the gland is deformed and distended. So I'm trying to gradually build up the sentence that there is a similarity not only in the anatomic structure, but also in the function as well as benign diseases. Which one is breast and prostate? Aging man has all these cyst-like cavities with increased pressure in it. In addition, there is this tissue that also compresses the urethra, called BPH, benign prostate hyperplasia. then he certainly has voiding problems. When fluid stagnates, it is going to be more and more concentrated, and that's what is called in the prostate amyloid bodies, in Latin, corpora amylacea. And that is going to attract to itself the calcifications. So here is the amyloid body, not calcified yet, and here are the prostate calculi. These are actually, under the microscope, very nice, laminated, oyster pearl-like, onion ring-like calcifications. You see it here. Didn't calcify yet. This one calcified. But the breast is very similar. These calcifications are in the breast. But they are so tiny, 40 or 50 micron, and we don't see anything on the 100 micron. So we are not going to be able to see this one and that one and that one. When they are grouped together within the terminal ductal lobular unit, then we see them. We call it cotton ball-like powdery calcifications. Dear colleagues, which one is the breast and which one is the prostate? This is in the breast, and this is in the prostate. So much about the benign. What about the malignant? They are so similar that they are indistinguishable. If I was asking you, is this the specimen of the breast or is this the prostate? What about the three-dimensional histology of a cancer originating in the duct in the prostate and originating in the duct of the breast? You cannot make the distinction even if you go down to the cellular level. Breast and prostate. The specimen X-ray of the breast is here and the specimen X-ray of the prostate is here. That fascinated me when I did prostate cancer research. And what really fascinated me most was that when the prostate specimen arrives to the laboratory and the pathologist looks at the ever-accumulating cancer cells originating from the cells lining the acinar in the prostate, they call it acinar adenocarcinoma of the prostate, AAP. Fascinating. Likewise, the other extreme, when the cancer cells are originating from the cells lining the ducts, they call it DAP. And it not only fascinated me because it was simple, but it fascinated me because it was right on target, namely the AAP and the DAP have direct relationship with the long-term patient outcome. As soon as you tell me AAP, I know the probable outcome in the long term. And I get goosebumps when you say DAP. Now that's what I call modern medicine. Instead of saying, like in a breast conference, luminal A, luminal B, ER positive, ECAT-herin, this and that. First of all, we don't understand each other. When they say DCIS or invasive ductal carcinoma, we don't understand each other because they use the term ductal, but it actually has nothing to do with the duct. So, despite many dissimilarities between the two organs, they have the similarity, that is, the cancers originating from the gland in the breast and in the prostate. A very low fatality rate. And fortunately, that's why breast and prostate cancers are good cancers, because 75% of all breast cancers originate from the gland, and as much as 90% of the prostate cancers originate from the gland. And we can control that. We cannot control the cancer of ductal origin, neither in the breast nor in the prostate, regardless of new therapeutic regimens. So it was really an epiphany for me. And I thought we really have to change the terminology in the breast and just call them brother and sister organs, AAP versus AAB, DAP versus DAB, according to the origin of the cancer. Because this is the most important in our activities as physicians. We really have to be able to have an educated guess quite accurately about the long-term outcome of the patients. It has been known in the literature, and we proved it too, that the DAPs, ductal adenocarcinoma of the prostate, have high Gleason score, they are large, they are metastatic, and they cause trouble. We had this unique case. The prostate cancer originating from the ducts infiltrated everything in the lesser pelvis of this man, But they look like DCIS in the breast. But it's not. It's an invasive carcinoma. It infiltrates the muscle of the urinary bladder. It infiltrates the fat. It drilled itself into the lymph vessel and gave metastasis, and half a year later he was dead in prostate cancer. Our research based on 100 total prostatectomy patients showed the same thing. Significantly better outcome of patients with AAP compared to DAP. So if the pathologist using a terminology in the prostate as simply and as efficiently as being able to tell the long-term outcome, why don't we use it in the breast? Dear colleagues, whenever you see stellate lesions on a mammogram, circular ill-defined lesions on a mammogram, and it turns out to be carcinoma, please don't call it invasive ductal carcinoma. They are originating from the TDLU. They are pre-stage, crushed stone-like calcifications, powdery calcifications, in situ carcinoma. Has nothing to do with the ducts. It's grade 2 carcinoma, grade 1 carcinoma in situ within the TDLU. And I will show you the corresponding fabulous long-term survival curves. On the other hand, when you see these neoduct genesis, that is, most of them are actually drilling themselves into the surrounding tissue. So it's duct-forming invasive carcinoma, either seen on the mammogram as architectural distortion without calcification, or seen on the mammogram as casting-type calcifications of one of the 4 subtypes. You can tell because it's long. This is not long. This is not long. This would be the DAB, and this would be an AAB. Significantly different outcome because the DAB is somewhere here. When you and I see on the mammogram cluster, multiple cluster, discernible, not discernible calcifications, and you do the core biopsy, and your pathologist says, grade 2 DCIS, just ask, why do you call it a duct when it is not? They say it's convention. By convention, they mislead people. So now I'm going to be practical for you, the practicing radiologist, namely, you find calcifications on a mammogram, and I understand that everybody is going to look at the shape, the density, the size, and how close they are, and so. But I'd like you to put the horse in front of the carriage and say, what was the location? And what was the location? Location, location, location. If the calcifications are ring-like, cannot be within a TDL, cannot be within the duct, and cancer only originates either from the duct or the TDL. So if it's out in the fat, in the fibrous tissue, that's not malignant type cancer. Let's practice this.